I'm honored to be invited to speak with you today as a geriatric specialist in physical therapy. This is really a common intervention in my clinical practice, as well as a central theme in educating both our medical as well as our PT disciplines. And so, yeah, the objectives today are to kind of primarily focus on the intrinsic factors influencing balance and fall risk, and review some of the evidence for exercise intervention for fall reduction, and hopefully help you to determine really what is the best intervention best suited for your patient needs. And so we all know that falls are really the leading causes of fatal and non-fatal injuries in older adults, 65 years of age and older. And over 28% of older adults report falling at least once in the preceding months. And obviously we need to ask them about these falls. But one of the most common causes of falls is actually due to trips, which contributes to over a third of the falls in community dwelling older adults, and about a fifth of those living in long-term care facilities. The physical environment really has a significant role in these incidents. That's why we shouldn't forget also about improving the home and community safe environment as well. But some of these falls are also related to intrinsic factors that due to sensory or motor decline in older adults, including vision, somatosensory, vestibular inputs, and also can be further impacted by some neurological conditions. And all of these really decrease those reactive balance strategies. So I wanted to touch on, the impact of this. So when a person or an individual has a goal-directed movement, this is really influenced by those overlapping factors associated with the desired task, the environment in which it's performed, and the capabilities or intrinsic factors which influence the performance of the individual. But most of our attention as healthcare providers is really usually directed at the individual, both managing their health conditions as well as providing some underlying measures through our review systems to determine, what are some of the factors influencing their balance. And as a physical therapist, I'd also consider how the function of these systems may be impacting an individual's balance and mobility. So, but understanding the demands of the desired task and the environment also allows us to really direct our intervention to address the physical needs that they need to be able to do to safely perform that sort of goal-directed activity. So I just wanted to take the time to review just some foundational components, since this may actually help you to understand and maybe even guide the selection of the best exercise interventions needed to reduce fall risk in your client. First of all, we talk about the musculoskeletal system. So we do a lot of measures with this, and this is usually the range of motion, the strength, maybe the muscle tone that's influencing or controlling the movement. It also influences what we call the borders of our limits of stability. And that's really when it's dictated when we need to take a step or a reactive step in order to recover balance. Some of those movement strategies refer to as what we call static strategies, which include strategies at the ankle or the hip in order to recover from just a mild perturbation, or anticipatory or proactive strategies, which are needed to maintain control, especially as we go to prepare to climb steps or maybe lift and carry an item. And then reactive strategies, and that's to recover our base of support or that control, such as when someone has a trip over an obstacle. And then the sensory strategies, which incorporates the use of the visual, somatosensory, and vestibular inputs. This really includes the function of these systems, as well as the ability to integrate and process that information. It also includes the ability to reweight that information if there's insufficient information coming from a system, such as decreased visual inputs or challenge, maybe from walking in the dark, or maybe actually even due to some impaired visual conditions. And then lack of visual inputs, especially for older adults, can be quite problematic because they have a tendency to be visually dependent. And even more concerning if you add additional conditions on which may impair other systems, such as like sensation with peripheral neuropathy, can really challenge that postural control. And then cognitive control includes, can be challenged as well by how much attentional demand is really required during that task. Older adults actually have more postural control challenge when the task requires cognitive attention. Their mobility is slower, their reactions are delayed. And then the cognitive ability to actually learn can assist with fall prevention strategies. But for patients with cognitive decline, we may need to focus more on intrinsic training, and the use of more task-specific training may be pertinent for these individuals. And then lastly, orientation resources is our ability to kind of perceive visual and postural vertical, which really aids in our ability to accommodate to especially changing or unlevel surfaces. So again, knowledge of these underlying factors impacting the person will really help us to direct what is the most effective intervention for them. And the needs of an older adult with just visual decline is much different from maybe for the individual who has Parkinson's disease or maybe has suffered a stroke. So exercise as a single intervention has demonstrated to reduce the risk of falls in community dwelling older adults, and several programs and research studies have explored both single item as well as multi-component exercise interventions. And what we do find that engaging in exercise overall has been shown to improve self-efficacy and really reduce the fear of falling. But which of these exercise modems is actually best is to be considered, and has been the subject of a lot of research. So Sherrington and colleagues in 2017 actually did a systematic review and meta-analysis to look at 88 random controlled trials. These were trials performed from January 2010 to 2016. Several of the research studies explored the use of structured exercise to reduce fall rates in older adults. Half of them were community dwelling older adults. The other were ones living in residential living facilities. It included conditions with Parkinson's, stroke, and even post-hospitalization. Some of the instruction, or a lot of the instruction, was targeted in most of these studies to have a small ratio of instructor to participants. And also a lot of the instructors were trained health or exercise professionals. So a summary of their findings from this research is shown here. Overall, they suggested that there should be a high challenge to balance, that there should be at least 3 hours of exercise per week geared towards, again, addressing some of those principles, and that there should be ongoing participation in order to maintain those benefits. So that kind of matches what we know as the use it or lose it principle. And that we should be thinking about prevention both for those that are fallers, but as well as those who are non-fallers, so that we're truly working on primary prevention. And that both group and home-based settings were found to be effective for community dwelling older adults. But walking and balance training, although found to be appropriate, brisk walking was not appropriate for those that are already at high risk for falling. And that we should also address some of those additional identified factors that we find, especially in those that are experiencing falls. And so overall, they found that, again, exercise as a single intervention actually can prevent falls in people with Parkinson's as well and cognitive impairment, but multifactorial approaches would be needed, especially for those being discharged from the hospital or receiving stroke care. But they did overall find that the rate of falls decreased by 21% for those living in the community, and that was even further reduced by 39% if the balance challenges were high enough and the intensity and the duration was long enough as well. So they kind of repeated this study again later in 2019 to look at not only looking at fall rate and risk, but also looking at the degree of certainty, considering bias to determine both the rate and risk of falls, but also the risk of fracture. And I thought that this was important because it provided even more insight into individuals that might need to seek medical attention, obviously become more costly, as well as the fact that these are going to potentially impact somebody's quality of life. So the interventions that were found to be most effective when they considered, again, higher levels of certainty were really those with multidimensional interventions. Balance and functional task-directed activities provided the highest certainty of decreased rate and risk of falls, and potentially the greatest reduction in fracture risk. A larger effect size was seen in many of these trials actually where a health professional actually provided the intervention. And this may be because it was possibly to providing more optimal or individualized challenges and progressive challenges. Also multi-component interventions, which included components of balance, functional tasks, as well as strength and gait, primarily for the aerobic capacity component, had an even higher reduction in rate and risk for falls, but potentially less impact on reduced fracture risk. And this, again, was surmised to maybe be related to less time spent on really the true components of balance and functional task. But this suggests that strength could have a significant role. But when they looked at the single intervention research studies that included things like three-dimensional activities like Tai Chi or dance or walking, or even strength training alone, these weren't found to have a significant impact. So I think the take-home message was really that there should be a suggestion of a blend of intervention approaches, possibly individualized with more attention to identify deficits. Could be especially more impactful for someone that's falling or at higher risk. And then whereas maybe a group program maybe designed with some of these principles may suit individuals that are at lower risk. So I just wanted to step through some of the details of some of these components. When we look at strength training for older adults in many of these research trials to decrease fall risk, some of the things that they looked at with regards to implementing strength training is that we really should focus on the lower extremities in order to really make an influence on stance control and reactive balance strategies. But upper extremity strengthening could also have an impact both on function. And we know that individuals sometimes fall when they have to lift a load or carry a load. And then the intensity was probably the other important part. And we know that muscle requires an adequate stimulus or an overload to get stronger. So really we're shooting for that minimum of 60% of their maximum available strength in order to actually make an effective improvement in strength. Exercises below that threshold might provide a modest improvement of about 5 to 10% on strength tests, but this has been found to be likely due to motor learning rather than biological change. Excuse me. And then power training, just wanted to bring attention to this because due to older adults' decline in strength and their delayed muscle reaction time, it is found that both strength and power training could provide that underlying support to react to those postural instability. And then functional movements, training muscle groups to mimic the movement pattern needed to perform activities of daily living like walking, squatting, lifting, reaching. This can actually promote both gains in strength and power, but also promote the motor learning to support those task-specific demands and have an impact on reducing fall risk. And then this is one of my passions, is working and addressing postural alignment in older adults, because this has been associated with several undesired functional and health outcomes. Hyperkyphosis has been associated with falls, as well as prevalent fractures, especially noted vertebral fractures. It can also impact the quality of life with decreased mobility and gait speed, its stair climbing ability, as well as balance. So specific exercises to improve, especially cervical and thoracic mobility, as well as extension strength in these areas, can really positively impact posture and also reduce falls. And then with regards to balance exercises, again, there's varying research to suggest that anywhere from 10 to 30 minutes a day is needed, 2 to 3 days a week, but there's consistent report that indicates balance, again, has to be challenged or challenging in order to reduce falls. And safety needs obviously need to be incorporated if you're putting these balance challenges in as a home exercise program. So one-on-one supervision may be needed or pertinent for training new challenges, and then highly recommended for those that are at high risk of falls or maybe even have a high fear of falling. So you can see there the progression of challenges that can be incorporated by implementing, sort of reducing the base of support, moving and changing surfaces, removal of those sensory inputs to remove that visual dependency, adding cognitive or manual tasks on, because we know dual task activities tend to challenge balance for older adults, and moving from more static to dynamic balance activities. And then anticipatory balance challenges are important. Again, we can implement those with obstacle courses, performing steps, performing lifting loads. This really helps to prepare the individual for those demands that they're going to meet in the community and in their home, with navigating steps or curbs, or having to be more stable when they're pushing open a door or lifting a basket of laundry. And reactive balance training. This is really what is needed when anticipatory needs are exceeded, when there's an unexpected change, again, in the surface terrain, or they get bumped into, or they incur a wet surface, or again, they trip over an obstacle. So providing high balance challenges, which really elicits a reactive response, is truly what we need to achieve in order to prevent the next fall. So task-specific training really allows that motor learning to provide the neuromuscular training to perform the task at hand. It allows us to grade the progression of the activity demand, but also expose them to fluctuating changes such as lifting loads, manual tasks, and even employing cognitive distractions. And the closer that activity or intervention mimics the desired activity, the more effective it is going to promote postural control and really decrease both fall and fracture risk. And so this is a chart that was put together to sort of assimilate a bunch of the community-based fall prevention programs. You can find more information about each of these programs on the NCOA website. And this table was a suggestion of best fit based on sort of fall risk level. And this was done according to the CDC study toolkit that was put out initially that designated low, moderate, and fall risk. Now they sort of have more of the suggestion not at risk or at risk. But I would suggest that the low fall risk includes individuals who have not experienced a recent fall, and you're really trying to employ efforts to prevent falls. The more moderate to high fall risk categories are more so for those that have maybe sustained falls or maybe even an injurious fall within the prior year. But I would also suggest that you might want to consider some physical therapy intervention initially with these individuals, and then maybe combine that with the format of some of these other programs that really provide a lot of education and more group exercise structure. So promoting adherence is probably the role of many of you as clinicians, and this is really where you can make a big impact on getting someone engaged in doing some fall prevention exercise. So whichever program or approach is really you determine is best to address that for your clinician, I think trying to think about, again, what supports that shared decision making, using some decision aids, whether it's brochures of some of the local fall prevention programs, or even sharing some brief summary of what I've provided to you today to sort of convince your client it's time for them to engage in some activities that will reduce their fall risk, especially through exercise. Connect the short-term goals of addressing those underlying impairments, the long-term goals towards addressing really what's going to make an impact on their desired activities, and really frame these interventions as not only improving their health, but also life enhancing, where it addresses what matters, really keeping them from falling. So there's my contact if you have any questions that you want to direct to me, and I'm glad to open up to answering any questions. Here are some of the references, and then here's also a final slide for a survey for you to give some feedback.